Hello everyone, very good evening to all. Hope all of you are doing good. In this session, we are going to have a short discussion of the MDS INI-CET November 2023 repeat questions. Just a quick recall of the questions from physiology. Over to the first question. The first question was on auditory mechanism, the hearing mechanism. The hearing, repeatedly we are seeing every year questions from auditory pathway and mechanism of hearing. So this has become a high yield topic. I think last exam also there was a sequence based question based on the hearing pathway. Arrange the following in sequence. The steps in the hearing mechanism. So again another question from auditory mechanism. Let's read the question. A 70-year-old patient who lives with his family members visits an intern doctor in the PHC for difficulty in hearing. The doctor realizes that the patient can only hear sound when shouted on or to amplified sounds. Which of these is the correct diagnosis for hearing loss in this patient? So the question is about the tests for hearing. The answer was moderate hearing loss is less than 41 to 55 decibels. So that was the right answer. Let's have a small discussion on the auditory mechanism, the hearing mechanisms, and then we'll come back to this option. WHO classification of hearing loss. The degrees of hearing loss. 0 is not significant. First degree, mild hearing loss. Second degree, moderate. Third degree, moderate severe. Fourth degree, severe. And fifth degree, profound hearing loss. And this side we have hearing threshold in the better ear. So now let's see how has WHO classified the hearing loss. 0 degree of hearing loss is 0 to 25 decibels. Mild hearing loss 26 to 40 decibel. Moderate 41 to 55 decibels, and moderate severe 56 to 70, severe hearing loss 71 to 91, and profound hearing loss above 91 decibel. First let's understand the mechanism of hearing, and let's also learn about few tests for hearing. The ear, external ear, middle ear and the inner ear. External ear. When sounds enter into the external ear, the sounds vibrate your tympanic membrane or the eardrum. From the tympanic membrane or the eardrum, this transmits the sounds into the ossicles. The middle ear has the middle ear ossicles, stapes, malleus and incus. From the middle ear, the sounds are transmitted to the inner ear. What are the parts of the inner ear? This spiral shaped round and round structure is the cochlea, responsible for hearing. What is the function of cochlea? Responsible for hearing, because the hair cells, receptor for hearing, is present in the cochlea. What are the other parts of the inner ear? Inner ear also has semicircular canals, atricle and saccule. What are they? Together, semicircular canal, atricle and saccule, they are called as vestibular apparatus. Vestibular apparatus. What is the role of vestibular apparatus? Vestibular apparatus, the semicircular canals, they respond to head rotation, and atricles, they respond to horizontal acceleration, and saccule to vertical acceleration. Let me write that. Semicircular canals respond to head rotation, atricle responds to horizontal acceleration, and saccule responds to vertical acceleration. Where do you think you will experience all this? Head rotation, horizontal acceleration, vertical acceleration. Yes, head rotation when you go on roller coaster. When the roller coaster twists and turns you around, head rotation. Horizontal acceleration, when you go at high speed on the highway, suddenly there's a brake. You experience horizontal acceleration. And vertical acceleration on a lift, on an elevator when you move, that is vertical acceleration. What is common to all these three? On a roller coaster or motion sickness or on a lift, yes, you experience some positional imbalance in all these conditions. That is why if your semicircular canal, atrial and saccule are strong enough, they can easily handle all this positional imbalance. See, if you see, if 5 friends go on a roller coaster, on getting down from the roller coaster, 2 of them will keep vomiting, and you'll see another 2, they'll get the token for the second round and they'll go and stand on the queue. So all that is because of your vestibular apparatus. If your vestibular apparatus is strong enough to handle all this head rotations and accelerations, you will not experience positional imbalance when you get down from the roller coaster. If your vestibular apparatus is not able to handle all this, only then you experience positional imbalance. So the role of vestibular apparatus is to maintain balance and equilibrium. Cochlea, responsible for hearing mechanism. That is what we are going to learn in detail. Let's zoom into the structure of this cochlea. The structure of cochlea. Cochlea is made up of 2 membranes. On top you have the Reisner's membrane and below basilar membrane. The 2 membranes are dividing the cochlea into 3 parts. The top scala vestibuli, middle scala media and below scala tympani. Scala vestibuli and scala tympani are rich in sodium. So the fluid contained in them is called perilymph. Scala media is rich in potassium. This fluid is called endolymph, and the potentials developed in the endolymph is called endocochlear potential. Normal endocochlear potential plus 85 millivolts. This potassium has a lot of significance. Very important point to remember here. The scala media is rich in potassium, and this potassium entry only is responsible for the hearing mechanism itself. Please remember this point. Scala media is rich in potassium. Now let me zoom into the scala media. There is a special structure called organ of Corti on the scala media. This is the organ of Corti. Let me zoom into the structure of this organ of Corti. Organ of Corti. This is the organ of Corti. On the basilar membrane, the organ of Corti. This is made up of hair cells, supporting cells, data cells and pillar cells. Hair cells are the most important one for us because they only contain the receptors for hearing. On top, hair cells are attached to the tectorial membrane. The movement of this hair cell only is responsible for the hearing mechanism. When sounds enter into the ear, it vibrates your basilar membrane. When the basilar membrane vibrates, so these are the hair cells. The 3 different orders of hair cells. The shorter ones, the middle ones and the taller ones. Shorter ones, the hair cells are called as stereocilia. Tall ones are called kinocilia. When the basilar membrane vibrates, it will push on the hair cells. The shorter ones are pushed towards the taller ones. So when the shorter ones are pushed towards the taller ones, they are all connected by tip links. So this is the structure of stereocilium, kinocilium and the tip links. The movement of this tip link opens up cation channels. So there is opening up of cation channel and cations enter inside. Now can you tell me which cation will enter inside? Usually sodium only enters inside and causes depolarizations and action potential. Only in the ear, this is one exception where potassium influx causes depolarization. Can you think why only here potassium is entering inside? Usually potassium has a tendency to move out only because the gradient, normal gradient for potassium is it is more inside the cell, less outside the cell. So normally potassium moves from inside to outside. But only in this inner ear hearing mechanism, potassium moves from outside to inside. Yes, what is the reason? Correct. Scala media is rich in potassium. This potassium only enters into the hair cells. And that is what is responsible for the hearing mechanism. Since scalar media has so much of potassium, this is the only exception in the body where potassium influx causes depolarizations. Now potassium enters inside. When potassium moves inside, potassium is also a positive ion, so it causes depolarization. Depolarization sets an action potential, and this action potential carried by the 8th cranial nerve, which is 8th cranial nerve, vestibular cochlear nerve. This is taken to the auditory cortex. When it touches your auditory cortex, on which lobe you have the auditory cortex? Yes, the temporal lobe. When it touches your auditory cortex, you are able to hear the sounds. This is the mechanism of how we hear. The auditory pathway, there are several steps in the auditory pathway. From the 8th cranial nerve, how does it reach the auditory cortex? And this pathway is called echolema. E for 8th cranial nerve, C for cochlear nucleus, O for olivary nucleus, L for lateral lemniscus, I for inferior colliculus, M for medial geniculate body, A for auditory cortex. So the mnemonic is echolema. Last year this was a sequence based question. All the steps were given, but in a mixed up way you have to arrange in this order. So this is called the auditory pathway. From the 8th cranial nerve, how the impulses reach your auditory cortex. That was about the mechanism of hearing. Quickly through this again. When sounds enter into your external ear, it vibrates the tympanic membrane, the ear ossicles, the inner ear, the basilar membrane. When the basilar membrane vibrates, it pushes on the hair cells, stereocilium, push towards the kinocilium. Opening of cation channels, cations enter inside. The cation which enters here is potassium. This is only exception in the body where potassium influx causes depolarization, action potential carried by the 8th cranial nerve to the auditory cortex, echolema, and that is how we are able to hear. What are the tests for hearing? A simple test, finger friction test. It is a quick and rough method of testing hearing by rubbing the thumb and the finger close to the patient's ear and ask if the sound is heard. So like this, you go near the ear and do like this. The patient should be able to hear the sounds. This is a very simple test for hearing, finger friction test. Watch test, same way. Instead of friction, you keep a small watch near the ear, bring it closer and check if the patient is able to hear. Watch test. He should be able to hear the tick tick sound of the watch. Other two important tests, Rinne's test and Weber's test. In Rinne's test, using a tuning fork, vibrate the tuning fork and place it over the mastoid area, over the mastoid bone, and ask the patient to raise his hands as soon as the sound stops. And as soon as the sound stops in the bone, you bring it to the air in front of the external ear, and the patient should be able to hear the sound now also. Even after the sound has stopped in the bone conduction, he should be able to hear in the air conduction, because normally air conduction is more than bone conduction. But if the person has bone conduction more than air conduction, what does this mean? There is something wrong in the air conducting pathway. That is why his bone conduction is more. So this indicates conductive deafness. Conductive deafness. Normally air conduction should be more than the bone conduction. So after it has stopped in the bone, he should be able to hear when you place it in front of the ear. Air conduction will be more. If he is not able to do this, if bone conduction is more than air conduction, then it is called conductive deafness. Weber's test. The vibrating tuning fork is placed in the center and it should be equally heard in both the sides. Normally it is equally heard in both the sides. Equal. If there is conductive deafness, So I place the joining fork on the center like this, or maybe like this also. If the patient has conductive deafness on this ear, it means his air conduction is affected. If air conduction is not there, all the unnecessary external noise is not heard. So without disturbance, in the same ear, he will be able to hear the sound more. So the sounds are more lateralized towards the conductive deafness ear side, to the same side, because conductive deafness, he has conductive deafness, he is not able to hear the external disturbance noise. So very well he is able to hear this noise. So in conductive deafness, it is lateralized to the same side. In this ear, if you have conductive deafness, in this ear only you will hear more, because there is no external conductive, there is no external noise entering inside because of your conductive deafness. That is why it is lateralized to the same ear. In case of sensory neural deafness, if suppose you have sensory neural deafness on this ear, it means there is something wrong in the inner ear. So obviously this side the sounds are not transmitted properly. So it will be more heard on the opposite ear. So this is lateralized to the opposite side in sensory neural deafness. Again, this is a very simple test to identify hearing loss. If you want to measure the hearing loss in decibels, then you go for audiogram. So in audiogram studies, we give different frequencies of sounds on x-axis, and you keep increasing the decibels of sound on the y-axis, and just check at what decibel which frequency of sound the patient is able to hear. For example, for any noise of 2000 Hz, a normal person should be able to hear it at this point. This is normal. The red line indicates normal. But if the person is not able to hear 2000 frequency of sound at this point, then you have to increase the loudness, because he is not able to hear. So you have to increase the loudness by 20 decibels. Only then he is able to hear. At this point only he is able to hear. So what does this mean? Only if you increase the sound loudness by 20 decibel, same frequency of sound he is able to hear. So how much is his hearing loss? 20 decibel is his hearing loss. If suppose you have to increase the sound to 50 decibels, only then he is able to hear the same 2000 frequency sound, then the hearing loss is 50 decibel. This is how we identify the hearing loss in decibels by using an audiogram. So back to the question. So when we identify the degree of hearing loss, the question was about identifying the true statements. Moderate hearing loss 41 to 55 decibels. So the more appropriate answer is option A, moderate hearing loss 41 to 55 decibels. All others are wrong. You can refer this table. All other options are wrong. Over to the next question. Which of these pigments gives color to the bile? Obviously, the color pigment bilirubin. Bilirubin is the one which gives color to the bile. Quickly about how hemoglobin is broken down to get bilirubin. The fragile RBCs, the older RBCs, they enter into the reticuloendothelial system to be broken down into heme. Heme, with the help of heme oxygenase, it forms biliverdin. Biliverdin is converted to bilirubin. This is called unconjugated bilirubin, because conjugation takes place only in the liver. So before entering into the liver, it is unconjugated bilirubin. It enters into the liver. What is released from the liver is conjugated bilirubin. Conjugated bilirubin, when released into the intestines, by the action of intestinal bacteria, it is converted to urobilinogen. Urobilinogen converted to stercobilinogen. On exposure to air, on oxidation, it forms stercobilin. This is what gives the yellow color to the feces. Some of this urobilinogen recycled back moves to the kidneys, and through urine it moves out as urobilinogen. On oxidation forms urobilin, and this is what gives yellow color to the urine. if there is any block in this pathway. The yellow color is transmitted to the skin and the mucous membranes and is called jaundice. What are all the blocks that can happen in this pathway? If there is any block, any obstruction, anything wrong at the level of liver, you call it as hepatic jaundice. If there is any obstruction or anything wrong before entering into the liver, pre-hepatic jaundice. After the liver, post-hepatic jaundice. What are the causes for hepatic jaundice? Anything wrong in the liver, hepatitis or hepatocellular carcinoma, any infection of the liver. Pre-hepatic, before entering into the liver, what could be the trouble? Yes, more hemoglobin is broken down. That is called hemolysis. So all hemolytic anemias, pre-hepatic jaundice. Post-hepatic. Post-hepatic is after the liver. Something wrong in the gallbladder. Cholecystitis, gallbladder tumor, gallbladder stone. Anything is wrong after the liver. Post-hepatic jaundice. So this is the breakdown of hemoglobin to form biliverdin, bilirubin, and the color to the bile is because of the pigment, color pigment bilirubin. That question, which of these is not a method of physiological heat loss from the body? What are the mechanisms of heat loss from the body? Especially anterior hypothalamus. This plays an important role in heat loss from the body. The mechanisms of heat loss by increasing sweating, by causing vasodilation, by increasing thirst mechanisms. When you drink more water, the heat is lost, it is getting cooled down. So by these mechanisms, anterior hypothalamus has a major role in mechanisms of heat loss from the body. Then what is the role of posterior hypothalamus? Exactly opposite. Posterior hypothalamus causes shivering. When you shiver, you produce heat. So posterior hypothalamus helps in producing heat, but anterior hypothalamus helps in losing the heat. A word about vasoconstriction and vasodilation. When there is vasodilation, the blood flow is more, so the heat loss is also more. In vasoconstriction, peripheral vasoconstriction, it is an important autonomic response to cold exposure which restricts the heat transfer from the core to the environment through the skin. If the blood vessels are constricted, it is giving a restriction for the heat transfer. So heat loss cannot happen in vasoconstriction. In vasodilation, easily there is heat loss. And that is why we go with this option, which is not a method of heat loss, peripheral vasoconstriction. It cannot be a method of heat loss. Over to the fourth question. Normal lifespan of RBCs. I'm sure all of you will know the answer for this. Yes, 120 days. So quickly through the lifespan of the different types of blood cells. Lifespan of RBC 120 days, WBC 13 to 20 days, platelets 7 to 10 days. The question was about normal lifespan of RBC. So 100 to 120 days. The most nearest answer is 100 days. Over to the fifth question. For how many days platelets circulate in blood? Yes, the circulation time is 7 to 10 days. Platelets can circulate for 7 to 10 days in circulation. That was about a short discussion on the physiology questions, recall questions that was asked in November 23 INI-CET exams. Any doubts you can post in the comment box. Otherwise, we are done with the session. Thank you so much for watching. Please join us for subsequent sessions also. Thank you.